Hello, and welcome back to another episode of CRNA School Prep Academy podcast. I'm your host, Jenny Fennell, and CRNA. And today we are going to talk about a day in the life of a CRNA. And so for those of you who are still trying to decide whether CRNA is the career path for you, I know you probably have a lot of questions, as far as what's out there, what is it really like to be a CRNA? And one of the best ways you can actually find this out is by spending time shadowing a CRNA. Don't wait until you're actively applying for CRNA school to start your job shadowing experience. Well, first, because it shouldn't be something that you only do to check a box on your application. You should really thoroughly be investigating what it's like in a daily life of a CRNA from the shadowing experience, so you can make sure that you're actually making the right career choice, because it's very expensive and it's very time consuming to become a CRNA. And if your heart is not in it, when you're in the thick of it in school, you're going to not only experience more burnout, but you may not even be happy enough to where you want to quit. So I don't want that to happen to anyone. And I'd rather see your time better spent in other areas that you would enjoy. So again, starting the shadowing process early is really key when it comes to determining whether CRNA is actually the right career path for you. And 9 times out of 10, when I talk to students and ask them, how they got interested in anesthesia, the vast majority of them have had some type of experience in the operating room or an experience with the CRNA that kind of opened their eyes to the possibility of being a CRNA themselves. And so again, it's kind of a really great way to kind of gauge whether you're truly passionate about pursuing this career path, is actually getting to see it firsthand and seeing whether you get that excitement. I know for me, seeing the CRNA at the head of the bed and knowing that was a nurse, that they were the ones and everything that they were doing for the patient was extremely exciting for me, to the point where I just felt that drive and that passion to pursue that as a career for myself. And that was really like my driving force behind everything I did from that day forward, that I made that decision to pursue CRNA. Now, if you're like me, I had heard a lot of nursing students talk about CRNA. Oh, they make a lot of money. It's the best nursing profession. There's a lot of autonomy. And, I think in nursing school, a lot of nursing students talk about it and maybe are not even necessarily serious about it, but they know it's a good profession. And that's kind of where I was. I didn't really know if it was for me. I actually didn't even think I could do it. I thought maybe I wasn't smart enough, that I wasn't ever going to be at that level to be able to be a CRNA. But it wasn't until I actually started getting some time in the OR as a nursing student that I actually had that flip in my brain switch on to the green light, the go. This is a go for me. And so I really encourage you to take that leap of faith and get that experience now, especially early on if you're still in nursing school. And so that way you can kind of just, again, engage yourself in the community and really start to see, can I picture myself in this career path? But today we're going to go ahead and get into some different things I've experienced. I also want to say to you guys, there's so many variations out there and there's so many different jobs out there that I've only experienced a tiny little portion of it. So talk to multiple CRNAs if you can, current SRNAs. That's really going to be a good way to kind of gauge what this career field's like, because there's so many different aspects and different careers, outlooks out there for CRNAs, that don't just take my experience. I really encourage you to try to seek out multiple experiences and try to gather all the information you can to come to a really great conclusion for yourself. Okay. But typically, and again, this is my experience working at a level 1 trauma hospital. I also have experience working at an outpatient surgery center, as well as a pediatric level 1 trauma hospital as well. So I have 3 different experiences to give to you. And they're relatively all, the days all look the same essentially as far as layout. But obviously there's definitely some differences between all 3 of them. Not in a major way, but definitely there is. So I'll kind of touch on that a little bit. So essentially I start my morning off. Okay. And, back where I worked for 4.5 years, I got very comfortable there. I did a lot of open heart, but I was very comfortable, meaning I could have a 7:15 open heart and roll in the door at 7:00 and be ready to go. I wouldn't say that as a new CRNA, I definitely didn't do that. And as an SRNA, I definitely did not do that. As an SRNA, you're always arriving very early before your CRNAs are even in the building. You're there as an SRNA, preparing your room, going to pre-op, getting ready for your day. And the reality is you're just slower at it when you're new at it. So you need to give yourself more time. The better and more comfortable you get with being in certain situations, maybe you can give yourself less time, but you still have to be ready. It was still on me, even though I got to work sometimes probably not enough time. I still had to make sure it was my responsibility to be ready for my room, because if it would look very poorly upon you if you weren't. So based on how far you live, give yourself time to get to work. I typically would say most CRNAs get to work right around 6:45 when they're in the parking lot, around 6:45 in the morning. And so that way they're out of the dressing room by 6:50, 6:55 and in the OR by 7:00. Most ORs start around 7:30 a.m. There are some rooms that start at 8. There are some rooms that start at 9. There's some rooms that maybe don't start till 10. Then occasionally some places routinely start at 6:30 or 6:45. So there's a lot of variation out there. So that's what I mean. It's hard for me to tell you what you're going to experience. It just depending on where you work. I spent 4.5 years. We would occasionally do a 6:45 start, and that was with the request of the surgeon for a particular day or case. That wasn't the norm, but there are some facilities that I rotated through as a student that would normally start, particular surgeons would normally start at 6:30 in the morning, and that was normal for that surgeon. So again, it can all be different based on where you work. Now, if you work at a level 1 trauma center, they never shut down. Okay. Surgeries happen 24/7, 7 days a week, holidays, you name it. Now, do they staff a full schedule on a holiday? No. Do they staff a full schedule on a weekend? No. Well, I should say back where I used to work, it got to the point where a lot of surgeons were taking advantage of having anesthesia staff there. So there were days that felt like a full schedule on a Saturday. Did they push the rules? Yeah, they definitely probably did at times with the kind of cases they put on the weekends. But if we were there to work, then we worked. And so again, every place is a little different. There's some places who the weekends are routinely slow, other than the occasion. And there's places where on the weekends can feel like a full day, like it's a full staff and full run day. So again, you're going to see variation in that too. But again, I would leave work, get to work around 6:45 in the morning, get into the OR by 7 a.m. If I had a 7:30 case, chances are I'm going to, between getting my room ready, drawing up drugs, checking my vent, looking up the patient, if I make it to pre-op, that's going to take up all that time. Okay. And then so literally the patient, I'll be just ready to go by 7:30, essentially, probably no time. And maybe I'll have time to run to the bathroom. Maybe I won't. Maybe I'll have time to swig my coffee really quick. Maybe I won't. A 7:30 start, you usually kind of hit the ground running pretty quickly when you get there. Now, again, in my own personal experience, I typically, at my other hospital, was level 1 trauma hospital, mostly adults that I did anyways. And I would have time to make it to pre-op for see my patient, check base with my attending, that kind of thing. Where I work now, that's not routinely done. But again, it's a different patient population. Pediatrics, you're typically interviewing the patient's family, not necessarily the 3-year-old itself. Plus kids can actually have, the more people you're introducing to kids, sometimes it can cause more anxiety for the kid. So again, we kind of try to keep the pre-ops to, a single anesthesia provider. So that way it decreases the anxiety for the family and for the patient. But you still want to check base with your attending. I always try to make a point to do that. Doesn't always happen. And sometimes that's okay. Sometimes you can get everything you need to know from the pre-op note that's in the chart, if it's a virtual chart or paper chart. But I still think checking base with your teammate, your partner, is the best way to go about anesthesia case to be the most prepared, because they may have missed something, you may have missed something. So it kind of works both ways. Again, once you're in the OR and the case, let's just say starts at 7:30, typical induction based on, now if you're working with kids, it could be an inhalation induction. If you're working with adults, a typical IV induction. I even have, where I work now, we take patients back who are 20 years old and still don't get an IV in pre-op and possibly still go to sleep before they get their IV, which, I don't think is super ideal, but it does happen. Doing an inhalation induction on a big kid is difficult but risky, because the stage 2 is, they have a lot of muscle mass. They, it's going through stage 2 in anesthesia. You could see, people will get very hyper reflexive almost, where they're like the whole body is heaving and they're almost trying to obstruct, and the risk of spasm is there as far as laryngeal spasm goes. They usually get tachycardic, and again, kind of like hyper reflexive, where they're just like tensed up, and agitated. And then they go through that phase where they relax after they get through that phase 2 of anesthesia. That's a safer plane of anesthesia to be in. But again, when you're doing inhalation inductions, you don't have an IV. You always have your IM drugs ready to go if you had to give IM sucks to break a spasm, or maybe with some Robenol as well. So keep that in the back of your mind, and even in an adult population, you always want to have your emergency drugs out and ready to go. But typically, if you're doing an induction with an IV, you don't necessarily see that prominent phase 2 like you do an inhalation induction, because the inhalation induction is what causes that phase 2 to be so significant. And when you're doing an inhalation induction. Now with an IV induction though, you got to worry about the burning of propofol. the dang propofol, it always burns. Every now and then you'll get a patient who's not sensitive to it, but it can be kind of harsh on your veins and feel kind of hot going in. So IV induction, it's really nice of you to use lidocaine to numb the vein prior to giving the propofol. I've seen people mix the propofol and lidocaine. I've also heard that that's doesn't necessarily even benefit the patient at all. I've heard mixed things on that, two different viewpoints. In my own personal experience, what works the best for my experience is when you give the lidocaine. Let's just say the patient gets in the room. Maybe you give some Versed, maybe you give some fentanyl, but the next thing you really should be doing is priming that IV with lidocaine. And when I say prime, I mean push the lidocaine down near the closest port to the IV and then kink it off. Let the lidocaine sit in that vein and not move anywhere. Just like if you were to do a beer block, you're essentially doing the same thing. You're concentrating that lidocaine in that one area to create a block, a local block. So when you're pushing 50 milligrams of lidocaine through a vein that's close to the hub, and then you don't run the IV afterwards, you're going to be letting it sit there and soak in a lidocaine bath. So when you do then push the propofol, they're not going to feel anything. Now, it doesn't always work out that way based on timing. Sometimes the timing's better than others, but if you can do that, that's, in my opinion, the best way to combat the burning of propofol, is to really let that vein soak in lidocaine prior to infusing the propofol. That same thing can be said for if you're doing a MAC case with a propofol infusion. Priming that IV with lidocaine prior to starting the propofol infusion is really the key to not having that vein burn, especially be aware and be cognizant on what side you have the IV cuff. Because if you're pushing that propofol and their IV cuffs or their blood pressure cuff is going up, that will definitely cause pain. So always try to be cognizant. Put the IV cuff on the opposite arm of the IV if you can. Obviously, sometimes you can't. If they have like an AV fistula or something like that, you can't use that arm for blood pressures. But you can always put it on the leg, to avoid that possibility of burning a propofol going in. If you're doing like a TIVA or something like that, you don't want every 3 minutes to have your infusion be kinked off by your blood pressure cuff. So you can put the blood pressure cuff on the leg. So there's just some little tidbits of typical things that you would see, based on, again, what type of induction you're doing. There's also rapid sequence induction, which is where you have high risk of having acid contents from your stomach coming up. And if you guys have ever heard of aspiration pneumonia, that is the risk with having a full stomach going under anesthesia, because you're fully relaxing someone's ability to close off their esophagus and windpipe. So again, you're relaxing that sphincter, that esophageal sphincter, so the bile can come up. You're potentially paralyzing and relaxing someone, so your vocal cords won't necessarily close off if they sense fluid. The gag reflex is pretty strong when you're awake, but when you're not awake, it's not strong. If not, especially if you're paralyzed, it's non-existent at all. So you lose the ability to protect your airway. So you're at high risk of aspiration, especially if you already have a full stomach. So again, we could do something called a rapid sequence induction, where we're actually giving the patient a little bit of what we call cricoid pressure, where we're pushing on the windpipe a little bit, essentially, and it kind of, the esophagus is below the windpipe, so you kind of squish potentially squish the windpipe or the esophagus a little bit as you're doing your induction. So if you did have bile come up, you're at least stopping it from coming all the way up. Those are like the typical inductions, whether you're doing general anesthesia, twilight anesthesia, or MAC anesthesia, which stands for monitored anesthesia care. And then if you're doing, again, an IV induction versus an inhalation induction, those are typically, and then obviously the style of airway, what kind of airway do you have? You could do a general without an endotracheal tube. You typically use something called an LMA. I have also seen plenty of generals done with an oral airway, especially, patients who come in with like blocks and are just on a propofol infusion. Technically, they're unresponsive, which is a general anesthetic without a secured airway. And LMA is also not a secured airway. You're not protecting. Technically, nothing's through the cords, nothing's through your through your vocal cords. The LMA just sits in the back of your tongue, and it kind of keeps your tongue from causing obstruction, and it allows you to breathe through that device. Same thing with an oral airway. It keeps your tongue out of the way. One just looks a lot fancier than the other. I love LMAs. I'm definitely not downplaying LMAs. They're great and they're very useful, but there's not a protected airway. So don't get too comfortable with the idea of having an LMA versus endotracheal tube. Always assess what your patient needs and their history, and assess their risk of potential aspiration is always the key important step there based on, what you need. You can also use maybe a double lumen tube if you need to drop one of the patient's lungs during surgery. So routinely in our thoracic surgery, or even in our mini AVR surgeries where we would do a mini sternotomy for aortic valve replacement, we could do one lung ventilation temporarily during the case to allow the surgeon to have a better surgical field to work with. And so these double lumen tubes, they're big, but essentially allows you to kind of clamp one side. So you can clamp the right or left side of your lung and drop that lung. Some patients tolerate that well. It depends on what their underlying base lung function is. Some don't tolerate it for very long at all. And so it's kind of a back and forth game of, okay, operate, do your work. And then when they get so low, I'll do my best to try to maybe give them some blow by for some, apneic oxygenation kind of situation where you're just blowing a little bit of flow into that down lung to allow it to expand a little bit, but not interfere with the surgeon. Sometimes that works, sometimes it doesn't. So a lot of different challenges you can face in anesthesia. Different types of surgical cases come with different challenges, and also different planning and different methods of providing anesthesia. During the case, for induction too, you want to decide what's the blood loss expectation for this case. You're planning ahead for that. You're saying, do I need 2 big bore IVs? Do I just need 2 IVs? Because maybe their arms are going to be tucked in a robotic case. And so if my one IV goes bad, not that I'm going to lose a lot of blood, but you still need a working IV. You can't go through a whole case without a working IV. And trust me, if your IV goes bad during a case where you have very limited access to the patient's extremities and feet, it is not fun. I mean, then if you really have no access to any limbs to start another IV, then you're talking about an EJ or an external jugular IV. So you always want to try to pre-plan for stuff like that and really assess what you think you need, and talk to the surgeon. Ask them, hey, what do you think your blood loss is going to be? Or how are you positioning this patient? Keep in mind too, if you have an IV from pre-op and your anacube, which is in the crook of your arm, my least favorite place. I think all anesthesia providers would agree with me that that's their least favorite place for an IV, because inevitably, if the patient's arm's bent in any way, now you don't have an IV. So it's essentially worthless. So you have to think about those things too if they come back. I've also had plenty of patients come back from the pre-op with infiltrated IVs. And then, so you don't really want to be cramming a bunch of drugs into someone's sub-Q. That's why you go slow with your induction. You assess the IV before you even start induction, make sure it's working, that kind of thing. So that's kind of covers like an induction of anesthesia. I'm sure I left some things out, but that kind of gives you guys kind of a brief overview. If you were to go in for a shadow day, you would see some of these things. And then after the induction, you guys, you kind of go into like the maintenance phase. During the maintenance phases, now the maintenance phase can be quick, meaning you could have a 10-minute case, meaning it could actually take you longer to sedate the patient than the actual case itself. That does happen. And that That's challenging for even an experienced CRNA, but I do think the more experience you get, the easier it gets because you're better about planning ahead for that. And timing wise, you're better at anticipating things. But essentially, if I have a room that's very quick turnover, what I do to kind of put my best foot forward is I get as ahead as I can, as far as I get drugs ready for maybe 2 or 3 cases down the road, or I look up those next 3 patients. So I kind of have an idea of what my game plan is. Or I even get like my tubes ready and make my tube burrito sacks, where you have like different, whatever size syringe you want to use, whatever equipment you think you need for the next case, you kind of have it in a little towel, that you can kind of hide in a drawer, keep it clean. So you try to plan ahead, especially if you know you're not going to have time during an anesthesia case to do that. But if you're in a case where you have plenty of time, I don't worry about it. Then you do your induction, you make sure the patient's settled. That's number one. You always put your priority on the patient. You want to make sure you're taking time to position the patient so they don't get any nerve injuries. That is very common, especially when they're paralyzed, they can't move. They can't tell you, hey, my shoulder hurts. Hey, my hands are going numb. They can't tell you that. So you have to really make sure, are their hands supinated? Are they off their ulnar nerve, which runs right by your elbow? Is their elbow adequately padded? Is their ear bent in half? Because if they're laying on their side, is your ear bent in half? Would you want to lay on your ear bent in half for like 3 hours? No, you'd wake up and you'd be like, oh, what happened to my ear? And even though the surgery pain's not that bad, my ear freaking hurts. So, or, I don't know, the pressure on the eyes. I mean, people have come out with optic nerve damage from surgery before. If you're not conscientious of, is there pressure on the eyes? Are they on their head the whole case and you're giving them tons of fluid? That's not good. I mean, you get orbital edema very quickly, especially if you're essentially on your head for the entire case. And some cases will have the patient head down the vast majority of the time. So you have to be really aware how much fluid you're giving. Obviously, you want to still have urine output and make sure that they're hemodynamically stable, but you have to be really aware that they're going to come out with swelling and you don't want to have their eyeballs be popping out of their head when you're done with the case. But yes, you go into the maintenance phase after you get them settled and you tend to the patient. That's when you do things like chart. That's when you do things like getting ready for the next case, drawing up those any drugs, and even anticipating the end of the case. So when I go into my maintenance phase of anesthesia, I start anticipating, what do I need for wake up? Is there anything I don't have ready? Do I have my reversal ready? What reversal am I using? Am I using Sugamidex versus Robenal or neostigmine? And why? Why would I choose one versus the other? And same with I like to, I always tell my students, I always have an oh shit stick, which is like my extra stick of propofol. You don't necessarily have to always have that drawn up. It is nice to have it ready to go because you never know any moment. What if they're coasting along and you see no vital increase, meaning their heart rates and their blood pressures train track? Then next, the surgeon does something that's very stimulating. And now, they're moving on the table and the surgeon's yelling at you. And you're like, I didn't even see that coming because they've been coasting along great. The oh shit stick is really nice for that. So I like to have, at least a syringe labeled and propofol out ready to go so I can quickly draw it up and give it. It also comes in handy if they're bucking on the vent, but don't be afraid to give paralytic. If you need to give paralytic, give paralytic. It doesn't take a lot to knock out those receptors. And so even if you're just giving 10 of rock, you're not going to burn yourself by giving 10 of rock, even if they're finished with the case. By the time they actually close and wrap things up and you're ready to actually reverse and extubate, that 10 of rock is going to be gone enough to where you can actually still reverse the patient. But dosing wise, you have to be aware of that and be cognizant that you're not slamming them with 30 of rock, at the end of the case when they start bucking, because then you could potentially hose yourself and not be able to reverse them unless you use Sugamidex. So anyhow, so that's just something to think about. It gives you guys something to put in your mind if you have never experienced OR life and during surgery and what the CRNAs do. But yeah, the maintenance phase is catching up on charting. Sometimes you have so much time that, you actually, again, have a decent amount of downtime and you just always scan the room. I think I scan the room about every 3 to 5 minutes. I would scan the room. And what I mean by that is I check, if they have a Foley, I check for urine output. Not that I document it every 3 minutes or every 5 minutes, but I at least keep an eye on it, because you don't want to get an entire hour into the case and have no urine output and not have even taken any steps yet to actually fix that problem. So you always want to be aware of how things are going. I always try to tell my students, anesthesia is about what's next. You want to try to really put your mindset in what's going to come up next. How can I be ready? And don't get me wrong, sometimes you're going to be wrong about what's next, or, because things can change rapidly, but it's still the practice of being or anticipating what is next is what makes a good practitioner, in my opinion. Trying to stay ahead of the game, trying to anticipate your patient's needs. And that way you're advocating for the patient the whole way through the case, all the way to the recovery room. So again, during the maintenance phase of anesthesia, you're assessing, do they have enough narcotic on board? Are they comfortable? And you do this by assessing their blood pressure, their heart rate, whether the patient's moving. And just because a patient moves does not mean they're awake. Even some surgeons don't understand that. And they'll say the patient's awake, and you're like, no, they're not awake. To have an entire MAC of gas, and this may be way over your head, and it's okay if it is. I don't expect you to know what this means. But one MAC of gas is, essentially a good anesthetic, but at one MAC of gas, 50% of your patients will actually still move to painful stimulation, which means there's no way you have any recall. There's no way you're going to remember any of it, but you're going to, if someone stabs you with a knife, you're going to have a reflex that says, ow, pull away, And so again, surgeons think that means the patient's too light, and that's not necessarily always the case. It takes a lot more gas to get them to not respond to that noxious stimuli. But that's why, in anesthesia, you're doing amnesia, analgesia, and areflexia. Areflexia is decreasing someone's ability to move with painful stimuli. And so that's why a lot of times, depending on the case, you actually need paralytic to help you with that. Because maybe you can't run them super deep on gas, because if they're super deep on gas, they're going to have no blood pressure, because gas itself is a vasodilator. So you see what I mean? You're always trying to think like, what's the combination of amnesia, analgesia, and areflexia that I need for this case? And guess what? All cases are a little unique and a little different, which makes anesthesia really fun, you guys, because it's never the same. Even if you take 2 lap choles, that patient will be different than the last lap chole. They may have different needs. Maybe one suffers from chronic pain. Maybe one's a redhead. It is true, you guys, redheads do tend to require more anesthesia. Not always true, but it does tend to be true most of the time. And it has to do with, they actually have more of an enzyme, cytochrome P450, that actually helps metabolize drugs. So just throwing it out there. If you're a redhead, you rock. I think you're beautiful. But I'm just think that's kind of an interesting little tidbit. My good girlfriend's a redhead. I love her. In fact, she's due to have her, totally off topic, she's due to have her next baby. And I hope and pray this baby has like the reddest hair. I'm just like hoping. So adorable. Anyhow. So that's kind of the maintenance phase of anesthesia. Part of the maintenance phase is anticipating the wake up. Okay. So emergence, that's another really critical part of the anesthetic, because every surgeon wants a smooth emergence. Okay. No bucking and no pain. And, it's a lot of pressure. Like, okay, I'll do what I can, but you can't always predict things. You can't always anticipate how things are going to feel. You do your best you can with the vital signs you have, and knowing how painful the actual surgery is. Also, did they localize? Did the surgeon take initiative to put some local in there? That'll play into how well controlled the patient's pain is. So there's a lot of different factors that go into post surgery pain control, and having the patient not care that there's a tube down their throat and cough, when they start lightening up on the anesthesia. So it can be challenging, very challenging, especially when you have a case like a thyroid who has a neck incision or a carotid. And the last thing you really want, if they strain, they can actually get a hematoma, which could be dangerous and life-threatening. So it can be very tricky and very high stress as a CRNA to do those cases without any bucking during the wake up. You always do the best you can. Some places will practice deep extubation for those cases. Not that deep extubation, it's totally fine as long as it's patient appropriate, but it can also be risky. You have to really be certain that you can get them through stage 2, like I said before, because they will go through stage 2. And if they go through stage 2 without an airway, you're risking laryngospasm. You want to make sure you're very diligent about recognizing the signs of laryngospasm before they are blue, sitting in front of you. So always being very attentive to your patient. One of the things you can do is, and you guys, I know I'm recording this on YouTube, but the podcasters, you guys can't see this, but I'm going to kind of suck in on my throat a little bit. And if you see how like the increase in my neck kind of dips in a little bit, if you see that in your patient, that's an obstruction. That's especially if you hear no air movement, that's a complete laryngospasm. If you hear a little like, or like a little like, I can't even make that noise. It's kind of hard to do unless I actually can make my cords kind of halfway shut. But you'll hear some cooing. That's a partial laryngospasm. That's better than a full laryngospasm, okay? If you get a full laryngospasm, you're risking flash pulmonary edema, because based on how hard they're sucking in to get that breath, they could actually cause like a negative pulmonary pressure to develop. It has happened. It's one of the dangers of laryngospasm. That's why you need to always have your succinylcholine ready to go, to give in case of an emergency, to quickly relax them. You don't want to paralyze them forever, but you want to try to break that spasm as quickly as possible. So based on whether you have a partial spasm, a complete spasm, and how bad you think it is in my opinion, how you kind of judge. Do you give propofol? Do you try to deepen them up? Or do you go straight to sucks? You don't want to risk trying to get someone through a laryngospasm if it's a complete spasm and there could be risking pulmonary edema. Just give some sucks, break it right away, take that risk away of pulmonary edema. So again, wake up can be critical, wake up can be challenging, wake up can be dangerous. It's like someone's always referred anesthesia like taking or like an airplane, like takeoff and landing are the most critical moments of the whole experience, because that's usually when things can go wrong, is induction and an emergence. Now things can still go wrong in the middle of the case, but just statistically, most of the time, if you experience a problem, it's during takeoff and landing or induction and emergence. So again, it could be kind of a high stress moment. It's again, when you're giving your full 110% attention to not just your patient, but what's going on in the operating room. I always, if people are not paying attention to you and what you need to make sure you're addressing that, because even the circulator should be paying attention to you and at your side. And that way, they're tentative. If you need extra help, if you need a second set of hands, that they're going to be calling someone to get them to the bedside for you, or be that second set of hands. Oh my gosh, I love my circulators. If you're out there, high five to you. You guys rock. I don't know what I'd do without you sometimes. I mean, like I said, just being there for me, even little things like holding cricoid, holding that tube. I've had them get supplies for me when I need it quickly, if I don't have it right by my side. And if the patient's spasming and I'm trying to give positive pressure and my sucks is over on my back stand, or I can't easily reach it, they grab it for me. And then, I can even, say, okay, give 1 cc, or I can even give them, direction. And they can really help you in a pinch. It's awesome teamwork. And again, everyone in the OR has their role. Everyone has an important role to play in the OR. So I think that's another thing too, as an anesthesia provider, that you work as a team. Every time you're in a case with someone, everyone in that room has a role to play. And especially as an anesthesia provider, you kind of can be kind of essentially kind of like a leader in that role of giving direction and delegation to what needs to be done for the patient, even to the surgeon. Don't get me wrong, this should be a two-way street, meaning you're not telling someone 100% of the time what to do, but you're having an open conversation is, okay, this is what I'm experiencing. Maybe let's try to work out as to why this is happening, because it's not good for the patient. And is there anything that you can do to help me out, or that I can do to change what's happening so we can make this better for the patient? It's always a two-way street. There's always room for someone else to come in there and help out and kind of help you essentially with the game plan going forward with the patient and the care. I talked about planning ahead for the next cases. Typically, you'll get a morning break, which is a 15-minute break. That can be different, and I'm sure you experienced it in nursing. It's not always guaranteed to get a break, but some days are better than others. Some days, like if you have time between cases, you better make sure you're going to the bathroom and getting that drink of water and slamming that cheese in your mouth, because you're not going to get a break. It's just too busy. They had 2 add-ons, and now the only free CRNAs are in rooms and all the attendings are busy. So again, keep in mind, as an anesthesia provider, sometimes you have to have very good bladder control. And I've now been pregnant 3 times in anesthesia. So I can tell you, don't worry, it's not going to make or break your career. If you really had to, you can call out, phone a friend. It's like, hey, if you're in between cases, can you come get me out? Or there's always someone to help you. If you're going to, don't pee your pants. But sometimes getting breaks can be hard in this profession. But typically a 15-minute morning break sometime in the morning. If I have a late start, meaning if I start at 8 or 8:30, I'll take my morning break ahead of time and cross myself off the list of people to break. It's the courteous thing to do. If you don't do that, don't just sit on your butt and do nothing. At least go around to other rooms and offer to help them get started. You never want to waste your time when you're at work. If you're on the clock, you're there to work. You're not there to sit and be on your phone. And the people who do that routinely will get kind of a bad rap. You really want to be that CRNA who's more proactive and going around and checking on people, offering them breaks if you have downtime. Does anyone still need a lunch break, a morning break? Again, if you have gaps in the day, try to be cognizant of who else can you help out then, because now you have plenty of time yourself. So make sure you're thinking about those things. But yeah, so if you do have downtime and everyone's cool, well, guess what? This is your time to drink coffee, socialize. Maybe you can work on some, computer stuff. Sometimes we have like continuing, like what do they call it? Like continuous learning activities that you have to do. So if you really truly have downtime, then you have downtime. You just don't take that downtime until you know 100% everyone else is okay. So again, lunch is typically a half hour, and that can happen anywhere between 11 a.m. and 2 p.m. Now, obviously, most time you hope it happens closer to 11 a.m., but depending on the day, it could be 2 p.m. before you're getting your lunch break. It just happens. It's not ideal. That's not what people strive for. But when you have one CRNA to give 15 or 10 breaks, and every break's a half hour, as you can see, that would take a very long time to get through all the breaks. So again, it just depends on the day. You can work till 3 p.m. You can work till 5 p.m. If you work the later shifts, you will be relieving people. And sometimes I used to work, I did 10-hour shifts. I've done 12-hour shifts, 16-hour shifts, 24-hour shifts. And the 24-hour shift usually covered OB. And so typically they were always free. They never usually were in a room towards the end of the day. In the beginning of the day, they were, but usually after 3 p.m., they can go rest for a little bit. Where I currently work, the 24-hour CRNA actually is usually the free person, and they go around and give breaks. And then after all the lunches are done, they go lay down until 3 p.m. and then they go relieve someone. So again, it can look different based on where you work, but typically the 24-hour CRNA gets some period during the day or evening to rest prior to the rest of their shift, because you may not get a whole lot of rest as a 24-hour CRNA. It just depends on the night. There are some nights where, man, it's brutal and you're running your butt off for almost the entire 24 hours. And then there's some nights where you maybe get like 6 hours of sleep. And so that's like the best scenario possible. But I wouldn't say that happens as often as the other scenario where you're running all night. So, and again, that's going to be different depending on where you work. But again, as a later CRNA, you're typically relieving people. And I actually think this is very challenging to relieve people, because you never know what you're walking into. You really never know. And so it can be kind of stressful to relieve someone, because again, you didn't start the case. You didn't position the patient. You didn't make the plan. You didn't dose the narcotics, but now you're challenged with waking them up. And maybe you would have done things a little bit differently. So now you're going to have to adapt to someone else's method and wake someone else up maybe differently than how you would have, because they did it differently. So not that that's, again, you have to be adaptable, but I do think as a later CRNA, you get very good at being adaptable, because you never know what you're going to walk into when you're walking into someone else's room. And again, everyone's going to have their own way, their own method, their own likes, dislikes. So again, it could just be more challenging, and it can be kind of exhausting, because like I said, the induction and emergence of anesthesia are really the most labor intensive parts. So when you're relieving people and you're waking up, that's a lot of work. And then you end that case, and then you go get another CRNA out, and then you wake that patient up. And so you're pretty much waking up all these patients on cases that you didn't even start. And so it can be very exhausting to be a late CRNA, because you feel like all you do in the evening is wake up other people's cases, and it can just be exhausting and a lot of work. And, so that's something to keep in mind. But as far as schedule goes, you guys can work any schedule you want. It just depends on where you take a job. You have to really seek those kinds of things out. You have to really know what you want before you graduate CRNA school. But I promise you that job is out there where you can get what you want. You kind of have to, again, is it more about location? Is it about money? Is it about acuity or case, what kind of cases you can do? Is it about independent practice? Is it about hours? You have to decide what's important for you. Chances are there's not a job that can do everything well. I mean, that doesn't exist. You're going to have to give and take on some things. Where I'm at in my career is I care more about hours. I want my schedule. If I can get my schedule, I don't care about everything else, essentially. I mean, to a certain extent, I can be flexible. So as long as I have my hours, I'm good. Again, I've worked 16-hour shifts, 24-hour shifts, 8-hour shifts, 10-hour shifts, 12-hour shifts, 13-hour shifts, 14-hour shifts, literally everything under the sun. I've tried and obviously came to the conclusion that 8-hour shifts for me, I like the most. It allows me to see my kids in the evening. Maybe there'll be a day where I want to work longer shifts when my kids don't want to hug me anymore, but for now they like hugging their mama. So I want to be there for them. So that's just me personally. I have other mom friends who prefer to have days off with their kids. So they work 12-hour shifts so they can have a couple days off during the week with their young kids and take them to the zoo during the day on a weekday that's not busy or stuff like that. So again, there's a trade-off. Being at work every day till 3 p.m. and where you always get your evenings with your family, or would you rather miss some evenings with your family to have a full day with your family instead? So that's just a personal preference. And again, you as a nurse are experiencing that. You do 12-hour shifts, you can do 8-hour shifts. But as a CRNA, I think there's a lot more flexibility. And another issue I had as a nurse is I was working night shift, and I hated night shift, not because I hated the actual shift, but because my body hated it. And I know that's very common. And I told another SRNA recently that I actually remember going to the doctor, having all this blood work done. So I thought maybe my thyroid was off, or maybe I was anemic because I just felt awful all the time, and everything came back normal. So it was just the simple fact that my body hated night shift. I never could sleep well during the day. Became kind of a vicious cycle trying to take sleeping pills and all other, it wasn't healthy. It wasn't healthy at all. And I'm so thankful that I don't have to resort to that anymore. But as a CRNA, other than doing the 24-hour shifts, I have never had to work a night shift. And typically you won't. They're not going to fully staff, nighttime. They're not going to do surgeries all through the night, but at least you have the option at some facilities to do 24-hour shifts. Some facilities may do 16 overnight shifts, like maybe from 3P to 7A, you can go in and work as a CRNA, or a 12-hour night shift, 7P to 7A. They may have that option out there based on the facility. I have not experienced that myself, just because we typically use 2 24-hour CRNAs to cover the nights. And then the 16-hour shifts sometimes didn't leave till close to midnight. So they kind of really help cover the really late shift OR cases. So it just depends. But for the most part, you can get away from night shift as a CRNA, which I think is great. So I hope that gave you guys a really good overview of typical CRNA life. I know there's probably another hour that I could probably share with you guys. And I will continue to do that on this podcast. So I hope you enjoyed what I could share with you today, and stay tuned for more. I hope to see you next week. All right. Bye-bye.